So the updates, April 2025. So if you are not in our WhatsApp group, because if you need this document to be sent over to you, you can be a part in our WhatsApp group. So we'll be sharing this document, all the slides and all. So just scan this QR code and please come in the WhatsApp group and you'll be able to access it. So I'll be stopping here for a sec. So if you are in the group, it's okay. If you are not, please scan it so we can share this document with you later. Right. So Down syndrome. So we have got a station. You are in surgery, GP surgery, and the patient is 46 and she has got some concerns, right? So talk to her, assess her, and manage. So most of the questions that nowadays you will see, they come like this only, that patient has got some concern. Go and talk to the patient. That's the main thing, right? So how can I help? I want to know whether I am at a risk of getting a child with the Down syndrome. So I just want to know. So you are like, okay, what is the reason behind it? The thing is, she is 46. So as the age increasing, obviously the chances of getting a child having Down syndrome is going to be high as well, right? So that's what you have to go with. That's what you have to ask. May I know why? I'm 46 years old and I heard that I'm at risk. Okay, so you have to ask about the pregnancy and all. And by any chance, are you pregnant? Yes, I got to know yesterday. So what she did the pregnancy test yesterday and she got to know that I'm pregnant. And she is 46 and she's worried I might be having a child having Down syndrome, right? So, and from where she got to know, she's like, my friend has a Down syndrome child and she got pregnant when she was at 45 degree. 45 years, right? And you can ask if she has got any other children. She's like, yes, I've got two. They're healthy, no problem at all. One is 16, one is 15, right? So this is something that you can do in the history, right? So when she got to know she's pregnant, if it's the first pregnancy, and how did she got to know about it, right? So all those questions, and what is her age? Her age is 46. Then quickly what you need to do is you need to take past personal social history as well. You need to see, for example, if she's having any past medical history, if she's a smoking, if she's drinking alcohol, if she's taking any drugs and all. So all these things are important as well, right? So when we took all those questions, everything seems to be okay. What she's doing, she's a makeup artist and she's living with the partner, right? So in Down syndrome, what are the screening tests we do? So what happened is that we have got, let me come here. So first trimester, roughly at 11 to 14 weeks, we do this test. That's a combined test that's offered to everybody. So what happens in this combined test? So we do two things. We do the blood test and we do the ultrasound scan. Right. So ultrasound is for knuckle translucency, and the blood test that you do is this plasma protein A. So it's pregnancy associated. So so it's PAPA A and HCG. So these are the two blood tests and the ultrasound scan. That's offered to everyone 11 to 14 weeks of pregnancy. So what happens is we'll see what is the risk like. Is it 1 in 200, 1 in 2000, 1 in 200,000? So what is the risk of a child having Down syndrome? It is not like very much accurate, but it will give you the number, like is it high risk patient or is it low risk patient, right? If because of any reason we are not able to do this combined test, so we have got a quadruple test as well. As we said, this is done between 11 to 14 weeks, but this is done between 14 to 20 weeks. 14 to 20 weeks. Here what we do, as the name is saying, quadruple test. So there are 4 tests we do. It's alpha-fetoprotein, HCG, estrol, and inhibin A. So this is what is done, right? Firstly, I'm going to tell you everything, and then I'll tell you what exactly we need to say if we get these kind of stations in the OSCE exam. So what are the things we have got? Combined test, that's done 11 to 14 weeks, and the quadruple test, that's done between 14 to 20 weeks. Now, what happened is, if for example, we got that risk is high, when we did the combined test and we found the risk is high, so what we do, we have a second screening test as well. That's non-invasive prenatal testing, NIPT. So this is also a blood test which can give you more accurate screening result and help you to decide whether to have a diagnostic test or not. What are the diagnostic tests we have got? That is CVS, chorionic villus sampling, and immunocentesis. Right? Let's do it again. So first we have got is the first of all we have got is the combined test, blood test, and you have got the ultrasound scan. Blood test, which blood test? Usually Papa A and HCG and the ultrasound scan to find out knuckle translucency. Right? So that's the test we do. If the risk is high, if the risk is high in combined test, we usually go and advise the patient to go for NIPT test. NIPT. The NIPT is actually much better test. It's more accurate screening, but it's usually not offered to everyone. It's offered to them who are at risk. Those who are like having high chances of having a child of Down syndrome in combined tests. Right. So if you have a lower chance, you will not be offered a further test. If you have a higher chance, you can decide not to have any further testing, or you can go for second screening test as well. That is NIPT, right? Right. And if somehow we were not able to do the combined test, the time period has, the window has gone 11 to 14 weeks, we can go for quadruple test as well. But I would advise you don't need to remember this quadruple. So just remember combined test. If the risk is high, we can go for NIPT as well. That's what you need to know. And if the risk is high there, then obviously we can go for the diagnostic tests as well. And the diagnostic tests will be CVS and immunocentesis. Now the thing is, in this case, should I mention about NIPT or not? I would advise you to mention actually. Why we need to? Because she is 46. So what we can tell her, we can first go for the combined test and then we can go for NIPT test as well, because the results are more accurate in NIPT test. Right? So that's what we need to do. So the patient is interested in knowing what are the chances of my child having Down syndrome and what are the investigations and the tests we can offer it to her. So first taking a bit of history, first 3-4 minutes, and then offering her like these are the tests that we have got for you. Right? Okay. All right. Now, there is a station on scleritis as well. Scleritis. Now, the candidates were like how to differentiate between scleritis and episcleritis. So we have posted a video on the YouTube as well, like how to differentiate between different ophthalmology cases. So if the presenting complaint is this, these can be your differentials. If the presenting complaint is this, these could be your differentials. The video is there on the YouTube itself. I'll send the link in the group as well. But nowadays, the station that's coming is scleritis or episcleritis. So when patient says, I've got eye pain, it's severe eye pain. When patient is saying severe eye pain, that is scleritis. And if patient is saying it is mild discomfort, it's a discomfort, not pain actually. So what is it? It's episcleritis. So remember, scleritis, episcleritis. Is it severe pain or is it discomfort? That's how you can differentiate. That's the first thing. Any symptom if you are having, it's going to be more severe in scleritis. For example, redness is there in scleritis. Yeah, it's there in episcleritis as well. Watering is there. Photophobia. Photophobia is usually there in scleritis, but you may not have that in episcleritis. All right. Vision loss. There might be mild vision loss in scleritis, but there is no vision loss in episcleritis. So firstly, you have to see if it is painful or not. Doctor, I'm having a bit of discomfort in my eyes. Or even if patient is saying pain, ask the patient to score the pain. And patient is saying it's just 3, 4, 5. So it's mild. It's going more towards episcleritis. However, if the patient is saying, oh, doctor, it's very severe pain I have got, then it's going to go more towards severe pain, going to go more towards scleritis. Okay. So that is the main thing. Right, and then obviously you will be ruling out differentials as well. If it is pain, then you have to look for keratitis, for example. Keratitis is, it could be bacterial infection, it could be because of herpes infection as well, right? So like herpes keratitis. So there might be a history of genital herpes. So that's why it's going to go more towards keratitis, right? Now, one thing that you will get in these stations, whether it is scleritis or episcleritis, what you're going to have is patient will have underlying medical condition. Usually, patient will have an underlying medical condition such as RA or IBD. inflammatory bowel disease or RA, and patient is taking medication for it. Usually these patients, you will see they might be immunocompromised. They are taking immunosuppressants, and that's the reason patient is going to have this pain or discomfort in the eye. Right. So when patient is saying I've got eye pain, elaborate it. Eye pain could be scleritis, could be keratitis, it could be acute angle closure glaucoma as well. So you have got a couple of differentials. Acute angle closure glaucoma, you have got pain in the eye, pain at the back of the eye, nausea, vomiting, color halos around the light, right? And red eye, obviously. So these are the things, these are the questions that you're going to ask. Scleritis and keratitis. Scleritis, you'll have underlying medical condition, for example, RA or IBD. If it is keratitis, so again, patient might be like the station that we have got is herpes keratitis. The patient will have a history, past medical history of genital herpes. A patient who had herpes in anywhere in the body, they are prone to get herpetic infection, maybe in the eyes, or maybe herpetic whitlow infection in the finger as well, or maybe genital herpes again. So that's what happens, right? So the presenting complaint will guide you. If it is pain, think about scleritis. Think about keratitis. Think about acute angle closure glaucoma. If it is just mild discomfort in the eye, think about episcleritis. Think about allergic conjunctivitis, isn't it? So you have to think about those problems. So if you get past medical history of RA or IBD, it is scleritis or episcleritis. If it is pain, severe pain, scleritis, mild discomfort, episcleritis. If the patient has got photophobia, vision problem, scleritis. No photophobia, no vision problem, most probably episcleritis. So that's how you need to differentiate on these things. Yeah. Examination wise, you'll do general physical examination, vitals, eye examination, right? And if it's scleritis and patient is coming to you in the GP, you have to refer this patient immediately. It's an immediate referral that needs to be done, right? Because scleritis has to be managed as soon as possible. Otherwise, it can lead to further vision loss as well, right? And if it is episcleritis, there is nothing much to worry. And ask the patient just to use maybe lubricant eye drops, and sometimes we do like topical NSAIDs as well, or maybe sometimes a topical corticosteroid as well. That's episcleritis. If it is scleritis, you might be admitting these patients as the patient is in pain, so you have to give painkillers as well, and the treatment is mainly corticosteroids, right? So first is topical, we might be giving oral as well, and you have to be very careful about immunosuppressants that patient is taking for maybe RA or IBD. So make sure that is being managed properly as well. That's the main thing, right? And then follow-up and warning sign, please make sure you always come for the follow-up. And if you feel the pain is getting worse and you are there is a further loss of vision, make sure you just let us know, because we are admitting the patient. So just tell the patient, let us know. That's the main thing, right? So this is how you can differentiate between scleritis and episcleritis. Okay. And as I said, we have got a video, 20 minutes video that is actually telling us you about all the presenting complaints and how to rule these things out, right? And I'm gonna send you the link in the WhatsApp group. Now, primary enuresis. Right, so let's have a look first of all, and then I'll tell you what exactly I wanted to discuss in it. So analysis is bedwetting, right? So first of all, what you need to do is you need to elaborate. The father is coming, the mother is coming, they're worried that my child is 4 years, 5 years, and they're doing the bedwetting. It's something normal, there's nothing to worry, but we need to know, is it primary or if there is a secondary cause behind it, right? So you need to ask whether it is daytime dryness, whether the child is wetting in the daytime also or not. And if the child had dry episodes before, what I mean by that, maybe the child was doing enuresis, bedwetting, but then there was like a few months, like 4, 5 months, 6 months, child was dry and then again started having bedwetting. So if there was a dry spell in between, and then they started doing bedwetting again, it might be secondary enuresis as well. So you have to be very, very careful on this part, right? So what you're going to ask, bedwetting, elaborate it a bit more, whether it is in the daytime also or not, whether there was any dry period in between. That's what you're going to ask. What else you're going to ask? You'll try finding it out if there is a reason behind it. So reason mainly that you need to look for would be dysuria, urine problem, and bowel problem. For example, the constipation if they've got, and if they have got dysuria or maybe UTI signs. That's very, 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 very important, right? And obviously, you need to look for like who is looking after the baby, who's staying at home, because you have to be very careful about the home environment. Maybe they were stressed because of the home environment and all, and that could be the reason of enuresis as well. All right. Now, what's the treatment for it? The treatment is going to be toilet training, avoid drinking before the bedtime, avoid caffeinated drinks, reward the child. Now, what I want to discuss here, reward the child. How to reward the child? I've seen some candidates saying, tell your child that if they will not wet the bed in the morning, they are gonna get a chocolate. So is that a good reward system? My answer would be no. It actually can create more problem for your child, because when the bedwetting is happening, it's nothing in their control. It's not in their control, isn't it? So I mean, if you say that if you will not wet the bed in the morning, you'll get a chocolate. So that can actually put undue pressure on the child's brain, a child's head. So the reward system would be like, do not drink before going to the bed. And if you pass urine before going to the bed, you will get reward. So child should be rewarded for these things, right? Then reassurance follow-up, referral to the pediatrician, maybe if the child is more than 5 years, and desmopressin, that is at night before social occasions. I mean, if you're going somewhere else and you might be like, okay, if a child is going to do bedwetting, it might be a problem. So for the temporary purpose, we can go for desmopressin as well, right? Now, recently what happened, the scenario that we got, the child was 7 or 8 years of age. So if the child is 7 or 8, is it always secondary enuresis or can it be primary as well, even if the child is 7 to 8? The thing is, it's possible. It's quite possible. There's nothing wrong in it. So what I understood is it's not like if the child is 8, it's always secondary. No, it could be primary as well. So you will ask the same question if there was any daytime dryness, or if there was like a dry period in between for a few months. And then you try ruling out the secondary causes like any UTI, any constipation, any psychological effect the patient has got. Or maybe the child started going to the school, or maybe there was a change in the school. They might not be liking that school environment, and that's why they started having this bedwetting things again, right? And management also remains the same, right? Now, should I refer this child to the pediatrician now because the child is 7? If it is primary enuresis, you don't have to refer the child now. Maybe tell the parents if they can try working on these things for next few months, and if that's not working, come back to us and then maybe we can refer you to the specialist. Even if the child is 7, 8, 9, it can still be primary enuresis without having any secondary cause. Got it? Now, what is well man and well women checkup? Right. So the thing is, you are, say, 50 years of age, 55 years of age, and you're worried about your health, and you want to go to the GP and want to get some tests. So you can do that. So which tests actually we do? So we've got many cases where the question is going to say that the patient went for well man checkup, the women went for well women checkup, and these are the blood test reports. Go and talk to the patient and discuss their blood reports, right? So we have got a scenario like on well man checkup, the patient is around 55 years of age, went for well man checkup, and what we found, the WBC count is 40,000. So you understand what it is. It could be a case of leukemia, isn't it? So that's the thing that we have got. So what are the tests we do? So well-done checkup when patient comes. So core investigation, general screening, what we do is the blood pressure measurement just to see the patient is hypertensive or not. We check the BMI, obesity. We do the blood test. Which blood test we do? We do full blood count. We do KFC kidney function test, LFT, and blood sugar we check, lipid profile, urine dipstick, and prostate health. Age 50 or more or symptomatic. If patient is symptomatic, you will do it. If they are more than 50, they can demand PSA test. Obviously, we'll explain them about the pros and cons of doing PSA. But even if they say, no, I want to go for it, you can do it. We have got informed choice program where we explain all the pros and cons of doing PSA. And then if patient still wants it, we can do it free of cost in the NHS. So that comes under well-man checkup as well, prostate, yeah. PSA, yeah. For the mental health, we can do depression and anxiety screening, smoking, alcohol, physical activity, all those things will be asked, and vaccination, flu vaccination, pneumococcal, and shingles, depending on the age. So flu vaccination is given to whom? Those who are at risk. For example, if you've got any chronic medical problems and all, so they will be given this flu vaccination. It's usually given in October or November, so that's the part of it. Now, is it the only thing we do in well-man checkup? Can we do something else as well? Now it depends. Sometime we may consider doing some other investigations as well. For example, the chest X-ray and all, depending on the history of the patient as well. But these are something that's done, but depending on the results, depending on the history, we might be adding some more investigations as well. For example, chest X-ray and all, right? What happens with the female? So there are lots of tests which are common. Obviously, the blood test measurement, BMI, full blood count, kidney function, liver function, HbA1c, lipid profile, urine dipstick, all these things are same. But then we have got something else as well. So for example, cervical smear test that's done from 25 to 49 years, right? So every 3 years it's done. And if it is 50 to 64, every 5 years it's done. And then if it is more than 64, then it's done depending on the stuff. I mean, depending on if there are any abnormal results previously. Okay. Then we have got the breast examination, self-examination, education, and clinical exams we can do. And mammogram is offered between age 50 to 71. Every 3 years it's done. 50 to 71 every 3 years. However, if there is a family history of breast cancer and all, this will be started a bit early. So instead of 50 years, we can start it 3 years ago. So maybe we can start it at 47 years as well. If there is a high-risk patient, there's a family history of breast cancer and all, right? And menstrual reproductive health review, PCOS, menopause, contraception, fertility, and all these things can be talked about. Same for mental health, depression, PMS, menopausal mood issues, and the vaccination. HPV, that's one, and then flu and shingles vaccine also we can talk about. So that's what we have got in the well man or well women checkup. So the scenarios that they give is usually the patient went for well man checkup or patient went for well women checkup, and the reports of well man or well women checkups are there in front of you. Go and explain it to the patient, right? So first of all, obviously you can say like, I've got the reports with me, but why did you have these blood tests? Oh, doctor, I was just worried about my health, and that's the reason I thought of going to the hospital and get all these investigations done. All right, and then what you do is start talking about these things, right? So well man and well women checkup. All right, let's talk about the scenarios. As I said, it's on 8th, 9th, 10th, 11th, and 15th. Nothing new was there. So there's a station on a psychotic patient. So the thing is, a lot of people say that there's a station on schizophrenia. See, guys, there are 3 things I would say. One is a delusional patient, then it's a psychotic patient, and then we have got schizophrenia. Delusion is patient has got delusion, right? Meaning, if patient says, I see police, I can hear them, but when there is nothing, I mean. So when you see things which is not there, when you hear things which is not there, that's come under psychotic symptoms, right? But when patient says, I just feel them, do you see them? Do you hear them? No, no. It's going towards delusion, right? Now, before you say schizophrenia, first of all, you make sure you have got a long history. You have to have a symptom for at least 6 months. Now, we have got the scenarios where they are giving you the history for 2 weeks, 3 weeks, 4 weeks, 5 weeks, and I've seen a lot of candidates saying it is schizophrenia. See, it might be, but it takes time to diagnose somebody with schizophrenia, right? So for this one, I would say what you need to say, it's a psychotic symptom that you have got or the delusional. You have to find that. Even the psychiatrists, they need to see this patient a couple of times before they diagnose the patient with schizophrenia. So please do not give your diagnosis as schizophrenia if the history is for just last 2, 3, 4 weeks, right? So be careful. I'm going to have a detailed webinar differentiating these 3 very soon: delusion, psychosis, and schizophrenia. But remember these things at least for now, right? Then we had a station on breast cancer. Yeah, so it's this normal history you were taking. Patient was 40 years, and you'll have some history like I've got a mass. So you elaborate the mass and you ask the cancer symptoms as well. You ask if there's any history of any breast cancer. You'll ask PPP question for the female, pregnancy, pills, pap smear, all those questions you can ask. And then we will do eyes, we'll do the examination as well. But the examination findings were given to you by the examiner. So this is how it works. Yeah, it was straightforward again. Then there was a station on interception, very old scenario. The presenting complaint was my child is crying, intermittent cry. He's crying for some time, then he's fine. He's crying for some time, then he's fine. So it is intermittent crying. That's what you have in interception, intermittent cry. And whenever he's crying, he's just bringing his knees to the chest. Very typical of interception. What will be the age group here? Roughly, the child is going to be 1.5 to 3 years or so. So usually 20 months old child is coming with this. They'll have vomiting as well. They'll have diarrhea. That is a red jelly stool. That's what is interception, right? And ultrasound, that's something that you can do. Interception is what? One part of the gut enters into other part, like a telescope. That is interception. Right. So air, barium, enema, that's what you need to do. Remember one thing, guys, that is the main point here. As child is having vomiting, having diarrhea, don't forget to rule out dehydration and don't forget to give IV fluids in the later part of the station in the management. I've seen people missing this part. When you miss this, you will miss the station, right? Mother will ask you one question. Is it going to subside on its own? That's the question. Is it going to subside on its own? The thing is, we have to do some interventions. It's not going to subside on its own. Okay. Then there is a station on essential tremors as well. The patient is having tremors while doing things and all. So the thing is, it's a young patient. So essential tremor can be there when there is no medical cause behind it, right? So what you need to do is, first of all, try finding it out if there is an underlying cause. I mean, if this patient is having any thyroid problems, for example, maybe this patient is taking any medication, any drugs, like say salbutamol and all, right? Another thing, if the patient is having Parkinson or not. So you need to ask questions for all these things. And when you're able to rule out everything, then it could be essential tremors, right? So essential tremors, need to find out the reason behind it. Sometimes patient is taking too much of tea and coffee, they're taking drugs, they're taking alcohol, so we need to make sure we cut that down. That's the main thing. Or if needed, we can give like propranolol to these patients as well. So make sure first you rule out other causes of tremors. Yep. Then there's a station on PID as well, right? The patient was having pain in the right iliac fossa, right? So it was straightforward. The patient was having pain. Anything else? The patient gave the history of vaginal discharge as well and having multiple sexual partner and everything. So it was easy. It was easy. One thing that you need to be very careful with, this patient is having coil inserted as well. But that was 2 years ago. So do you think this could be the reason of PID? Maybe yes, maybe no. I mean, if infection is now, it looks less likely to be the cause, but it can be. So, treatment is antibiotic, treatment is treat the patient, treat the partner, offer HIV test, that you know, fine. My question to you is, if the patient has got coil inserted, it is still in place, but that was inserted 2 years ago. So, when you offer the treatment, would you be interested in taking out this coil, or you will let the coil, there it is? Answer this question. The coil can stay, or you want to remove the coil for now? Do you want to remove the coil, or coil can stay? The thing is, the management would be, for now, coil can stay. But start the patient on antibiotics, and if the patient is not improving and it's been 3 days time, 3 days time, patient is not improving at all, then you may consider removing the coil. Because with this thing, it doesn't look like that coil is the reason, because it was 2 years ago it was inserted, right? So for now, maybe let it be there, but patient is not improving with antibiotics, remove the coil. Right, so that is a very, very important point. Don't miss. So my tip, one trick here is, any female patient, if you get, please guys, don't forget periods, pregnancy, pills, pap smear, partner. I'm not saying you have to ask these 5 questions to the patient. I just want you to screen these questions quickly in your head, because they might be very important. So please make sure you don't miss it. Yeah. Then we had a PSA follow-up. scenario, right? So the PSA was it's as a follow-up case. So what happened is if PSA is high, it doesn't mean you have cancer, and if PSA is normal, it doesn't mean that you don't have cancer. So this is a very tricky part, right? So it was a follow-up case, but the patient was having symptoms. But when we did PSA, it was normal. So you just need to have to do the examination, and you will have you'll have BPH there. So that was the station. Then the Simban sepsis. So make sure you do proper A, B, C, D, E. Then there was a colonoscopy counseling after sigmoidoscopy. So it was a colorectal polyp station. So what we did sigmoidoscopy and we got the colorectal polyps. Now the question is the consultant, GI consultant has advised the patient to go for colonoscopy. But the patient is like, you've already done one test, sigmoidoscopy, and now you're doing colonoscopy. It's kind of the same test. So why are you doing it again? It's not making sense for the patient, right? Why did we do sigmoidoscopy? This patient was having a complaint of bleeding from the back passage. So it was a bleeding from the back passage. That's why the sigmoidoscopy was done, and sigmoidoscopy shows colorectal polyp. So why are we going to do colonoscopy? First of all, we will be able to scan the whole colon. Sigmoidoscopy, we can reach to only a certain part of our gut. But in colonoscopy, we can, check the whole gut. That's one. Number two is, if we found the polyps, we can treat it at the same time as well. That's why we are planning it, right? Then there was a station of oxybutynin toxicity. The patient was having urinary symptom and the patient was prescribed oxybutynin. And the patient gave the history that while I was on this medicine, I had some funny sensation. He was a bit like, was forgetful. So that could be a side effect of oxybutynin. So we need to adjust the medicine, this oxybutynin, right? Then there was a case on AS. It was ankylosing spondylitis, the pain, it's a back pain station. Guys, in this one thing I would like to say, candidates are studying to make the diagnosis here. In the exam, they'll have these positive findings. The patient will have pain in the morning and gets better as the day progresses. And it should be at least more than 3 months. That's the positive history you're gonna get. Plus, when you say, I would like to do the back x-ray, the back x-ray shows, patient has got sacroiliitis. So this is ankylosing spondylitis. That's it, right? So there are things you need to mention. So if you get pain and the back x-ray shows sacroiliitis, this is ankylosing spondylitis. However, I would like you to ask some other questions as well in this. For example, uh, because in the back, what's going to happen? There will be limited movements in the lumbar spine as well. Ask for chest examination as well. These patients you usually have got limited chest expansion as well. So when you do the examination, mention I would like to do general physical examination, vitals, your back examination, and I would like to do chest examination as well. Usually because of AS, because of bamboo spine, they will have limited chest expansion as well. And it's going to be going more towards ankylosing spondylitis. Also, I would like you to ask extra articular symptoms as well, which you usually miss. Eye symptoms, eye pain, uveitis. That's also you can ask. So when you say the examination, you can mention about eye examinations, right? And AS usually will have a young patient as well. So don't miss that. Otitis media, ear. So ear, we have got again so many scenarios. Again, I can send you a link of the video, 15 minutes again, and you can have a look at that video, and it will cover every single question you might get for ear, right? Otherwise, the station for otitis media will be patient will have a pain, and then they'll have the fever as well. These are the main things, right? And make sure you rule out meningitis. That's the main thing. Yeah. Ask for if the patient has got a hearing problem or if the patient has got any balance problem or not, right? So when it comes to the examination, you can't do everything. So you just do what is there in the history. So pain, fever, you can do otitis media and you can do otoscopy. When there is no hearing problem, there is no balance problem. So there is no need to do hearing test or balance test. Remember one thing, don't forget to ask the patient about the allergy in the past medical history. This patient is always allergic to penicillin. And if patient is allergic to penicillin, you have to give something else. Please don't miss that point. Yeah. Then the station on late colleague, that's straightforward. Then patient they're traveling to Thailand and requesting for antibiotics. Do we give antibiotics in this way? Not really. But you can talk about the patient about the vaccination if they have done the vaccination or not, travel vaccination and all, right? So that station has already been discussed. So uh, first of all, we have to ask when they are planning to travel, because for vaccination and all, it has to be at least 6 to 8 weeks before they travel. They need to tell us so we can do the vaccination. Who else is traveling? Maybe the wife or husband is also traveling, so you can take history for them as well. If they're up to date with the vaccination or not. For the antibiotic, usually it's not given. However, if the patient is immunocompromised, for example, patient is diabetic, patient is on cancer treatment, patient is having ileostomy, colostomy. So in those cases, we might be able to give prophylactic antibiotics as well. But usually it's not given. All right. Then we have got a case on hyperparathyroidism. It's a counseling case. It's written in the question, it's hyperparathyroidism, right? So hypercalcemia symptoms you can ask and make sure this patient is not dehydrated. That's the main thing. Then there's a prescription, community acquired pneumonia. That's a prescription that you need to write. That's straightforward. Then was a tinea, it's a ringworm, a fungal infection. So that station again, it was straightforward. Yeah. Then on the 9th, there's a station on STI. So again, I think that is straightforward. Gastric cancer is one of the comparatively, it's a new station, but then it's easy. The presenting complaint was indigestion, but this patient was having loss of weight and loss of appetite as well. Please don't forget to do eyes. Subcutaneous injection teaching, that's straightforward. We have got the video again on the YouTube for subcutaneous teaching and IM injection teaching as well. But mostly in our exam, it's a subcutaneous injection that is coming. Remember just one trick here, the needle that you will use to take the medicine should be different from the one you use to inject it to the patient. That's the main point, right? And before injecting, just when you're teaching, just tell the student that make sure you rule out allergies and all, you check the expiry date of the medication, all those things. In subcutaneous injection, you don't need to clean the area, you can straight away give it, and you don't need to aspirate before giving the injection because we don't have any major vessels in the subcutaneous tissue. That's the main thing, otherwise it's straightforward. Then there's encephalitis, straightforward scenario, right? Then there's alcohol counseling. This patient is willing to quit. This patient has got insight. Insight is there actually. Remember one thing in this, sometimes this patient says, I have tried quitting it, but I couldn't. When you ask why you couldn't quit, the patient said, I used to have withdrawal symptoms. So you can say like, okay, this time we can refer you to Alcohol Anonymous group and we can give you some medication for your withdrawal as well. That is the thing, right? So that's something that's going to be quite helpful. Yeah. Okay, then we have got acne steroid induced. The patient is a young guy and is having acne, and the patient is taking a steroid. He's saying Dana. What we think it could be Danabol. So that could be the reason of acne. Yeah. Post knee arthroplasty counseling. Yeah. So just worried about when I'll be able to walk, have to look after myself when I'm gonna go home. Straightforward. Leukemia, this is again, as I said, a well-man checkup. Sometimes they give the patient has got splenomegaly, and sometimes they give the patient is having a WBC count of 40,000. Sometimes they have even given the WBC count is 100,000 as well, right? So I think you can easily manage it. Amlodipine side effect, swelling legs. So the presenting complaint here is the swelling. So when the swelling in the legs there, so you will think about a lot of things, isn't it? Swelling in the legs, the problem could be with the heart, with the lungs, with the tummy. So anything, I mean, isn't it? It could be heart failure. It could be the problem with the liver as well, problem with the kidneys as well. That's why this swelling is there, right? But it's coming and going. For how long it's there? For last maybe a couple of weeks only, 2-3 weeks. And then you got to that amlodipine was recently added in the medication of this patient. And one of the common side effects of amlodipine is swelling in the legs. So you just stop it and change it to something else. Yeah. Then there's an ethical scenario. Don't tell my mom she has cancer. So when she was admitted, she was confused. So we discussed about the issue with the family. But now the patient is competent. So if the patient is competent, are you going to tell everything to the patient? Of course. But the son is saying, don't tell my mom she has cancer. So you have to explain that. You have to tell because it is the patient's right to know about her condition. Right? Then there's a diarrhea, it's a Clostridium difficile CDAD scenario, right? So I think that's easy. The patient was admitted because of pneumonia. The patient is on antibiotic, and then patient got diarrhea. We did investigate. We found it is CDAD, and then we have to give another antibiotics to the patient. And then son has got some concern. You're supposed to talk to the son and do this counseling. Yeah. Then there's a station on SIMMAN post CS pain management. This one I want to discuss a bit. So patient was given intrathecally morphine. So cesarean section happened 6 hours ago. Now patient have got pain in the tummy. Children are fine and with the father in the other room. It's a twin delivery. And patient was given intrathecal morphine. That was 6 hours ago during the induction of anesthesia. That's given. All things are given to you either in the question or when you go in, the hospital notes will have this information. Now this patient is in pain. Go and talk to the patient and management. So when you go in, as it is SIMMAN, so what you will need to do in SIMMAN, you need to check the vitals. And the vitals of this patient are normal. The vitals of this patient are normal. Now, sometimes the examiner, what they do, they ask you to fill the news chart. National Early Warning Score. So nowadays they're asking us to fill a news chart. I hope you know it. Yeah, so we did discuss that also in the previous webinars. So you have to fill the news chart, right? That's okay. Now, the patient is in pain. What could be the reason? Because when we give intrathecal morphine, usually it's effective for 8 to 12 hours. But again, it depends on patient to patient as well. Some might be having pain a bit early than the other one, right? So before we give any other medication, what you need to check for this patient, check for urine, because if the patient is catheterized, the urine bag or urine pipe is not kinked, for example. So check for urine. Check for bowel as well. I mean, if they're passing wind or passing stool. Check for if there is any internal bleed, or check if there is any sign of infection. Internal bleed or any sign of infection. The thing is, infection, I don't think so. Infection is they're gonna be there very soon. It takes time, isn't it? Internal bleed, I think I'll get the idea if the vitals are abnormal. But I said vitals are normal. So urine, bowel, internal bleed, infection. Ask one more question: if she is doing the breastfeeding or not. NHS, the nice CK's guidelines tells us to ask at least these 5 questions. On the basis of that, now we will decide which painkiller should be given to this patient. Yeah. So, patient is doing breastfeeding. So now patient was given morphine. So which painkiller I should be giving? When I did the examination, the wound is very clear. There is no internal bleeding. There is no external bleeding. No bleeding, I mean, right? So the treatment that I'll offer is paracetamol, 1 gram IV. If patient is still in pain, I'll tell the patient that I've just given the treatment. It will take some time to show its effect. If patient is still in pain, can I give morphine again? The answer is yes. Tell the examiner that I will be keeping an eye on the vitals of my patient. I'll involve my senior as well, and we may consider giving morphine to this patient. That's it. Remember one thing, in this case, the codeine is contraindicated. Sometimes the examiner asks, okay, after morphine, what you can give once the pain settles a bit. So what else? So we have to come down the ladder. Usually in the cases, we go up the ladder, but in post-op cases, we come down the ladder. So from morphine, when you come down later, you will never give codeine to this patient because codeine has got the maximum chances of neonatal respiratory depression if the patient is doing the breastfeeding. So be careful on this point. So if not codeine, actually in the hospitals nowadays, you will see dihydrocodeine is given. That is okay. So just remember this point. Yeah, so that's the station on sim and post CS pain management. Then there was a nail infection, paronychia. The patient, the pain, I mean, the station presenting complaint is a pain in the big toe. And I've seen candidates making one silly mistake. Pain in the big toe, their mind is taking them towards, doubt. No, it's pain. And the patient said, I hit the toe on the wall, and that's how the pain started and all. So just be careful on it. Yeah. Primary enuresis, that also I have discussed, but I told you one thing when you get a case on primary enuresis. Yeah. That is it, even 7, 8-year-old kids still can have primary enuresis. Yeah. Then there's a prescription on acute pyelonephritis, that's straightforward, and then subconjunctival hemorrhage. So subconjunctival hemorrhage, I just woke up this morning and I saw that one of my eyes red. That's your subconjunctival hemorrhage. Yeah, that should be okay. So that's straightforward, actually, not a problem. Just see, is it in one eye or both the eyes? That's the main thing. So one eye, both the eyes, because if it is in the both the eyes, it could be a sign of early stroke as well. Please check in the history patient is on any blood thinners or not, right? So these are going to be your red flags. Yeah. Then 10th, what we had is lower urinary tract symptoms, but prostate was normal. That's okay. Then there was a fall. We have to counsel the patient for CT scan. So the CT scan criteria is in adults, make sure you remember. And you need to take history in during, after, and before. Usually this patient gives a history. After the injury, the patient vomited 3-4 times. And that was the criteria of doing a CT scan. Don't forget that one. Mumps orchitis, so they have a testicular mannequin. So that's how you can get. The patient says, I've got pain in the testicles for last 1 to 2 days, but having fever for last 2 weeks. When you're like 2 weeks, how? Patient was having mumps as well. So that's mumps orchitis. Don't give antibiotics, guys. Yeah. Down syndrome counseling that I've just discussed in the beginning. Tension headache, yes. So the patient has recently got the promotion and started having this pain. Sometimes they give you the history of neck pain as well, neck stiffness as well. That can be their intention headache. And nowadays, this station is coming with the eye mannequin as well. Fundoscopy, it's going to be normal fundus. Yep. Post-MI depression. The patient had MI and now patient is in depression. This patient is not compliant with the medication as well. The patient is not compliant with the medication. It's saying like, sometime when I forget, I feel like, should I take double the dose the next day? That's not the case, isn't it? So you need to do the counseling as well. And please ask a question for depression, mood, and hedonia, how's your eating, sleeping, and all those things as well. And don't forget to ask for suicidal history as well. Okay. Then we have got rivaroxaban PE prescription. Yeah. Upper J bleed, some man, just make sure when you give high flow of oxygen, you may not be able to give the mask because that patient is having bleeding. So you might be going for nasal prongs as well. Yeah. Then the stational Riluzole counseling. The patient has got motor neuron disease and patient is demanding Riluzole. Riluzole is given only by the specialist. We junior doctors, we are not going to give. And patient is actually on regular follow-ups with the specialist every 3 months as well. So let the patient go there and they will decide whether it's given or not. It's not given to everybody, it's given to some patients only because it can lead to lots of problems to your liver and to your lungs as well. For example, in lungs, it can cause pulmonary fibrosis. Before we start this medication, we might be doing liver kidney function test and a chest x-ray as well. So that's the main thing. Then there's station on delayed discharge, colleague, error, mistake, that's straight away. Worried about dementia, that's straightforward. There's a station acute appendicitis, that's fine. Post-menopausal bleeding, please investigate. It could be a sign of cancer as well. Yeah. Then there's a station on palpitations. Palpitations. This station was actually the patient is drinking too much of tea and coffee. That's the main thing you will be getting in this scenario, right? Then there's the epilepsy follow-up, and according to the patient is taking the medication regularly. Patient is taking, I'm taking it once a day. But when you check the prescription of the patient was prescribed it ED. So just listen to the patient carefully. Don't miss this main part. Another day there's a station on ADHD. Yeah, the person, the patient is saying, I've been referred by the student counselor. And he was having this problem before as well. It's not like recent, it was there when he was in school as well. But nobody paid attention. But now in the college, the student counselor referred this patient to the specialist, right? He's not able to concentrate on things and all. Yeah. Then you try in February. This again a test. It's a teleconsultation, and it's like the reports are given to you in the question itself. Yeah. HIV test reports, straightforward. Meningitis prophylaxis. So he's worried about getting meningitis because the patient had a contact with somebody who got meningitis. So you have to give the prophylaxis. Which medication, guys, you give when you give meningitis prophylaxis? It's used to be rifampicin, but now we give ciprofloxacin. Yeah. Remember one thing. Remember one thing. Uh, you will give ciprofloxacin because, but if somebody you gave ciprofloxacin and somebody got meningitis, you might be repeating the prophylaxis for everybody again. And this time it's not ciprofloxacin, it might be rifampicin. Just remember this. Yeah. Hypoglycemia case, and this patient doesn't want to stay in the hospital. You need to convince it's a straightforward scenario and very old scenario. Insomnia, depression, straight away scenario again. Prescription morphine, syringe driver, straightforward. And the Simban morphine toxicity. So when you start this station, the patient respiratory rate is very low. They say it's like 5, 6 only. And you will use the pen torch, and this patient has got pupil constriction as well. Yeah. Osteoporosis medication counseling, it's alendronate counseling actually. So when you have to do the proper counseling, what you're going to do is you'll tell everything. What is the use of this medication, how you are supposed to use, and what's the side effect of it, everything. So it's like you have to take it empty stomach with 1 glass of water, and once you take it, you don't lie down. Otherwise, it can cause infection, esophagitis. That's something that you need to mention here. All right. And tell your dentist that you're taking alendronate because it can cause jaw necrosis as well. Yeah. Then there's a combined station on adhesive capsulitis or frozen shoulder. Straight away scenario. And then on frozen shoulder, what happened? The pain. When you get the pain, first few months, it's going to get worse. And then it will start getting better. Right? So main thing is, it's a combined station, as I said. Main thing that you have to do in the examination is the movements. You may not be able to do everything, but don't forget to do the movements. One thing you will get in the movements, that would be active and passive. Both the movements are affected actually. Yeah. And which movements usually? Usually flexion is affected and abduction is affected and external rotation is affected. So don't forget this. And the treatment is keep your arm mobile. That's the thing. Yeah. And keep your arm mobile, and we can give some steroid injections as well. And mainly is the conservative management. Yeah. One thing that you can't afford to miss is this patient will have, in our exam, 100% of the times we'll be having diabetes mellitus. And it's a known and very important risk factor for frozen shoulder. Don't forget to talk about diabetes management as well in the end. Lifestyle advices and control diabetes. Yep. And there's a station on female catheterization as well. Yeah, teaching. And there's a station on surgical abortion. Then there was a station on acute cholecystitis, Murphy sign you're supposed to do. So, and the mannequin was there, so that can be done. Then there's a station on Kawasaki. Kawasaki or scarlet fever, strawberry tongue, yes, but the history here is going to be, I mean, more than 5 days, and the treatment is IVIG and aspirin, right? Antibiotics are not going to work in Kawasaki. And don't forget to take care of the heart. 2D echo will be done as well. Scleritis, presenting complaint is pain, pain, pain. So don't forget that. Yeah. Scleritis or episcleritis. I've seen people giving the diagnosis of episcleritis here. When it is severe pain, it is scleritis, guys. Yeah. Okay, then on 15th, yesterday, deafness. It was a station on acoustic neuroma. Now, the thing is, I've still seen a lot of people in this station, they're doing otoscopy as well. See, the presenting complaint of the patient is a hearing loss, and then they have got balance problem as well. And still, I've seen a lot of people doing otoscopy. It doesn't make sense. So you have to see what's the presenting complaint, what is the associated symptom, and you will do the examination accordingly. You can't do everything. So just be careful on that as well. Yeah. And acute exacerbation of asthma, symptom. So ABCDE. Prescription was on pyelonephritis, straightforward. Viral encephalitis, you're talking to the father about the son, so that's straightforward. Post-MI depression, straightforward. Endometriosis. Here, it was a straightforward scenario. The patient is having bleeding, and the thing is, she is saying she's not sexually active now, but she was sexually active. That time, patient was having dyspareunia as well. And this patient has already been to the GP, and GP has given the diagnosis of endometriosis already. So the thing is, you just do eyes, and I would say you will have the diagnosis. Yep. COCP repeat prescription. The patient is already on a COCP, and the patient wants further COCP. Shouldn't be a problem. Now, remember one thing, when the patient comes to us the first time asking for contraception, we give a supply of 3 months. But if patient is coming for or calling us for repeat prescription, then we can go give it for 6 months as well. Can we give it for 6 months? That should be fine. But in the history, make sure you rule out the contraindication. Make sure you rule out the contraindication for COCP. All questions you need to ask, like any hypertension, any blood clots, any stroke, hypertension, diabetes, migraine with or epilepsy. So all those things you need to rule out. Now she has got one question that I'm very happy taking CUC. I've been taking it for 1 year. Now I'm going on my holidays and I don't want my periods to come. So is there anything that you can suggest? Yes, we can suggest something. So what you can suggest is the patient should continue this. Like in COCP, we have got it for 21 days and then we have got a gap of 7 days. But tell the patient not to have this gap for 7 days. Continue taking the combined pills and you will not have your periods. That should be absolutely fine. Yeah. Hyperthyroidism, that was straightforward. Scabies, that's okay as well. Mesothelioma, yeah, there are two scenarios on mesothelioma that's coming. One, the presenting complaint is hemoptysis, right? And then this patient is a construction worker. So I think it should be okay to give the diagnosis, right? Another one is we did the chest X-ray because we did the chest X-ray for one patient, and why we did it? Because patient had a fall. Just to rule out other things, we did the chest X-ray. And accidentally, we found these findings: pleural thickening. That's what is given to you in the X-ray. So that is an accidental mesothelioma. That is something sometimes a bit difficult to diagnose. But the one presenting with hemoptysis, it's easy. So they're giving both actually. Sometimes presenting complaint of hemoptysis, but sometimes accidental finding of pleural thickening. In both the patient is construction worker. Don't forget that. Yeah. Incontinence, straightforward, just look for tea, coffee and all. And the breech presentation of 36. So that is an examination station actually. So 36 weeks. So, and the patient has delivered twice previously as well, normal vaginal delivery 2 times before. So now at 36, what you will do, wait for 1 week. And when it is 37, then you may try for external cephalic version. If that's not successful, you can try again ECV. If that's not successful, we go for cesarean section. So that will be your management. Yeah. Then there's station on amoxicillin rash. It was a medical error. Yeah. So that is straightforward in the very old scenario. Then there was Morton's metatarsalgia. Morton's metatarsalgia. The patient is wearing heels, pointy heels, and that's why they've got pain between second and third metatarsal. That's the main history they will be giving it to you, right? Morton's neuroma, and they have got numbness, stinging in that area as well. So that's why the metatarsalgia is a very generalized term, right? So usually the name is, instead of Morton's neuroma, I would say you should say Morton's metatarsalgia, right? I'll send the scripts as well, the new scripts that we have got where this scenario is very much explained as well. So I'll send that again in the WhatsApp group, yeah. And then the reactive arthritis here. I've seen a lot of candidates, they made the diagnosis of STI here. Don't make that mistake. The patient is starting with, I'm embarrassed to talk. I'm embarrassed to talk. But when you say, tell me what's happening, I'm here to help and all, then they'll start talking to you and they will give that I've got penile discharge. So when we hear this word penile discharge, patient has got multiple sexual partner as well. So we don't ask more of open question. We conclude and say it's STI. No, when you ask anything else, this patient has got a joint pain as well. Are they going to give you eye symptoms? Not really. They have not given in the last exam when it came, coming yesterday. But be careful. It's not ST, it might be reactive arthritis. Can't see, can't eat, can't climb a tree. So urethritis, it's there. Ask anything else, they'll have joint pain as well. I've seen people missing this point and giving the diagnosis of STI, right? Then there's a case patient doesn't want to inform the partner, but when you do the proper counseling, the patient agreed as well. But remember, if it is a diagnosed case of HIV, if patient is refusing to inform the partner, what you can do, you can still inform the partner. You cannot force the patient to inform the partner. You cannot force the patient to inform the partner, but as a medical practitioner, it's your duty to inform the partner, right? That's what you do. But as I said, when we explain to the patient properly, they agree to us in this scenario, right? So yeah, that's it, guys. That's it. What I've got for